Hi, I'm Dr. Neil Barshes. I'm a vascular surgeon at Baylor College of Medicine in Houston, Texas. The single biggest improvement that people can make in their presentation skills is to really work on the first sentence of the presentation. The single biggest thing that I would say regarding the first sentence is to save the laundry list of comorbidities for later on in the presentation. It's been too common for people to begin their presentations like this. I saw a 68-year-old man. He has uncontrolled diabetes, hypertension, hyperlipidemia, OSA, CKD, CHF, forefoot gangrene, status post BKA, hypertension, hyperlipidemia. He's got 3 brothers, 1 sister. He's a Gemini, et cetera, et cetera. A presentation like this, already before we even get to the chief complaint or the primary problem, my working memory is at capacity. I'm juggling all these things. I'm trying to figure out if I could put them down because they're not relevant, or I need to continue juggling them until I figure out if they're important to the primary problem. So, if I'm doing this, I'm either mentally taxed or I'm frustrated and only partially listening. Just avoid that situation altogether. In most situations, the best first sentence strategy is to say what you think the problem is, or if you know it's an obvious problem, you state the problem, and you might even propose a management plan in that first sentence. So here's an example. I saw a 68-year-old man with an abscess, a foot abscess in the ER, and I think he would benefit from an operation. So that is putting up front what you think the diagnosis is. It then allows the hearer, the person who's listening, they're not going to be burdened by the mental tasks of sorting through information, trying to organize it, and then determine its relevancy. Rather, they can just listen, and all the other things that you say subsequently, they'll be able to figure out, is it congruent or not congruent with what you have said is the diagnosis. So in this strategy, you're more like a lawyer. You're stating a position and you're making a case. And I'm going to stress that the statement of the position comes first. You put your chips down on the table and then you argue that point. So it's more like a lawyer, less like Goethe's Faust, where the journey, it's all about the journey. Here, patient presentations, for the most part, you don't want to take the person on the same journey you went through to sort through the information. It's generally best if you just talk about what you have found to be relevant. There might be times where you're not sure what the diagnosis is. You know what the problem is, but you're not really clear, or you're not confident in one particular diagnosis. So the second best strategy, the better strategy in a situation like this, is that you just simply state the chief complaint, the reason for the consult, or why they're in the clinic, and you just leave it at that. Example, I saw a 72-year-old man. He's here for an appointment to evaluate exertional pains in his left calf, period. That's it. So you may have noticed that in both of these examples, I left out comorbidities altogether. I didn't mention anything else. There's no abbreviations. There's nothing other than the chief complaint. Just age and a gender noun, man, woman. I told you earlier, you should not list all the comorbidities, but at the same time, there are some times where you do need to list certain comorbidities, specific comorbidities. This is not like the TV show Lost, where the other person wants to get a surprise midway through the story. No plot twists, no surprises. Important things should get listed up front. How do you determine what's important? How do you determine what you should include in the first sentence and what you should leave for later on when you get to the past medical history, past surgical history? 2 main categories. First category is what I would call game changers. These are diseases or problems that are either pervasive, they're terminal, or they're in some other way very influential. Metastatic cancer is often in this category. Hospice state for Something else, multiple debilitating strokes might be another. Some problems like this, that belongs up front. The second category would be things that provide context that is important or even crucial to the interpretation of the primary problem. So what is crucial or what's important? Let me give you some examples that I think will make it pretty clear what to include and what not to include. Here's example number one. I saw a consult, symptomatic carotid artery stenosis in a 65-year-old woman with advanced glioblastoma brain cancer that's been recalcitrant to radiation therapy. First sentence there. So this is an example from that first category, a game changer problem. Putting that in the first sentence in this case for that pathology, glioblastoma, that would be important. Putting in the first sentence pathology like this doesn't necessarily mean that you're not going to propose that this woman wouldn't benefit from an operation. But at the same time, the alternative, if you were to not mention it up front and instead you leave it for later on, you've talked about a TIA, you've talked about imaging at another hospital that showed significant severe carotid stenosis, but then you don't mention the glioblastoma until later on, that wouldn't be ideal. So something like that you mention up front. Example number two. I saw a 58-year-old woman, diabetes, hypertension, hyperlipidemia, OSA, CKD, CHF, prior lap appendectomy, prior left hernia repair with prosthetic mesh, who's here asking for a refill on her albuterol rescue inhaler. So here's an example where, again, laundry list, totally unnecessarily, totally irrelevant for what is a pretty clear problem, need for a refill on a rescue inhaler. None of these things are relevant to that problem. Here's a third example. I saw a 40-year-old man with sudden onset upper back pain, period, end of first sentence, versus I saw a 40-year-old man with a prior diagnosis of Marfans disease who is reporting sudden onset severe upper back pain. So in the first version of it, without mentioning Marfan's disease, there is, at least initially, several potential causes that could be at play. If you include Marfan's disease, then it allows the other person to immediately focus on a particular problem, a very specific problem, and a very important one. And I'll mention here that even if you ultimately conclude that this is not an aortic dissection, it's not anything that's actually related to Marfan's disease, in this situation, it's a man with Marfan's disease and upper back pain. If you don't talk about it up front, if you don't recognize the possible association between upper back pain and Marfan's disease up front in the first sentence, then I think you're making a serious omission here. Final example, a 75-year-old man who was scheduled to have an EVAR next Monday has come here for sudden onset flank pain. Here the diagnosis is pretty clear. The man has a known AAA. He's scheduled for an operation, and now he's got sudden onset back pain. You just state that one sentence, and I think already, your presentation is pretty much done. I don't think anyone's going to say, oh, hold on. What's his A1C? Or does he smoke? It's just, he's got a very clear problem, and comorbidities, other things, it's not really going to influence the interpretation of that problem. That's the first sentence. Like I said, state what you think is the problem, what you think is the pathology, plus or minus the management plan up front, overall the best strategy. Next best thing is to just state or reiterate really the chief complaint, the primary problem. A few minor suggestions. First, I would say limit abbreviations to those that are pretty much universal throughout the field of medicine, not just within our specialty, but throughout the field of medicine. or maybe some that are not only used within our field, but also that our team specifically uses them. There's a lot of jargon. There's a lot of abbreviations. There's a lot of abbreviations, for example, that are used in orthopedics, day in, day out, that I don't know. You may be familiar with them with your, if you've rotated on orthopedics recently or have some orthopedic interest, whatever, but I may not know them. So don't risk any kind of misunderstanding just based on an abbreviation. Second, when it comes to describing prior operations, it's probably better to just say prior or previous operation for problem. For example, prior hemigastrectomy for gastric adenocarcinoma, or prior hemigastrectomy for peptic ulcer disease. So, I'm giving that example because a given operation can be done for multiple indications, and to interpret the significance of what that prior operation may have now, it is typically important to know what the indication is. Not always, but usually. So it's usually best to say operation for problem, like Whipple for pancreatic cancer, prior Whipple for pancreatic cancer. If you say it the other way around, a lot of times people say pancreatic cancer status post Whipple. I'm thinking, does the patient have active cancer, pancreatic cancer in the remnant pancreas after having had a Whipple? It's just not the most accurate way to describe it. So it's prior operation for problem. And while you're at it, I would say just drop the status post. You don't need to say status post. And I know, other than wearing clogs, it's probably the single most thing that makes people feel surgical to use the phrase status post. But just use plain language. Just say prior operation for this problem. So hopefully these suggestions will help you with your first sentence. It's a real critical sentence. It's going to get people either engaged, listening, and interested, or if it's not done right, frustrated, mentally overtaxed, and maybe disengaged. So spend some time thinking about your first sentence.